play the video? Yeah, thank you.
As we know, the annual volume of TAVR has increased each year, and in 2019, TAVR volume exceeded all forms of SAVR, coincided with the US FDA approval of TAVR for low-risk patients. Among the patients younger than 65, recent US data showing that by 2021, the odds of a patient under 65 would receive TAVR versus SAVR were about 50-50. In this regard, TAVR has consistently shown better results than surgery, and the focus is shifting more towards valve performance, such as hemodynamics. Data from surgical AVR demonstrated that patients with moderate or severe PPM had increased risk of readmission for heart failure and reduced surgery. Survival are significantly worse for any degree of PPM. The use of a small prosthesis was an independent predictor of 10-year mortality. Actually, higher residual gradient affect late mortality in both TAVR and SAVR. Severe PPM was associated with increased mortality and heart failure readmission at 1 year after TAVR. TAVR has consistently shown better results than surgery in forward flow hemodynamics. Although the differences in mean gradient after the procedure was slightly over 3 millimeter mercury, there was a four-fold difference in number of subjects with a mean gradient over 20 millimeter mercury in surgery compared with TAVR, and a threefold increase in the occurrence of a small area in surgery patients compared with TAVR patients. That is, a small differences in mean gradients appear to translate to a large difference in index of bioprosthetic valve stenosis. Through 5 years, significantly lower rate of bioprosthetic valve dysfunction with COVA or elevated R TAVR versus SAVR were demonstrated. Therefore, as we move the indication of TAVR to more active, younger, and lower risk patients, we should not tolerate PPM because it may compromise long-term survival. From the hemodynamic study, the gradient is proportionate to the area available for flow, which is related to the square of the EOA radius. Below 2 centimeter square, the area available for flow rapidly diminishes. Hence, we need to achieve an EOA of approximately 2 centimeters square before we can substantially raise aortic flow without a large increase in transvalvular gradient. In the TVT registry, in 62,000 patients that include patients treated with both Sapien and Evolut valves, severe and moderate PPM were present in 12% and 25% of patients respectively. The use of smaller prosthesis of less than 23 millimeter and the valve-in-valve TAVR procedure were important predictors of severe PPM. That is, in patients with a small annuli and the TAVR in SAVR procedure have elevated gradients versus patients undergoing TAVR in native valves. And there is a trend throughout, showing that elevated gradient have been associated with increased leg mortality with a p-value of 0.09. Actually, among various available TAVR devices, the largest EOA have been achieved with supraannular self-expanding valves, approximate or exceed 2.0 centimeter square. Both the balloon expandable and the self-expanding valve that are approved in the US have been shown to be effective treatment options. With, however, balloon expandable valve demonstrate equivalent to the hemodynamics performance to the surgical valve, but self-expanding valve demonstrating superiority in terms of EOA compared to the surgical valve. In a recently published long-term follow-up data comparing intra versus supra-annular valves in mortality and the hemodynamic performance, intra-annular valve showing that higher transaortic gradient and the accumulated incidence of hemodynamic valve degeneration and the bioprosthetic valve failure predominant, occurring in the smallest valve size 20 to 23 millimeter intraannular valve, even though the overall survival was comparable. In summary, for a substantial number of patients with a small aortic anatomy at high risk of PPM after TAVR, self-expanding supraannular valve demonstrated superior hemodynamics. In study in REDO TAVR registry, actually TAVR in TAVR shows similar outcome versus TAVR in SAVR. Specifically, TAVR in TAVR had a higher instance of a mild aortic regurgitation, but lower frequency of residual high valve gradient compared with TAVR in SAVR. What have we learned from TAVR in SAVR is that with the surgical valve in the native aortic annuli, there is a lack of space in the aortic root for the TAVR valve, which makes achieving optimal hemodynamic performance a challenge. How to modify this? We can choose a supraannular valve. We can put the valve higher, and we can use a bioprosthetic valve fracture. Small label size of the surgical valve is associated with inferior result after valve-in-valve procedure. In the Edward Sapien group, there was a negative trend between the bioprosthetic size and the high post-procedure gradient rates. That is, we should avoid balloon expandable valve in small surgical valves. Furthermore, implantation depth matters. In those patients, even with the self-expanding valve, if you put the valve too low, the under-expansion effect will be demonstrated because of the annular will constrain the opening of the valve. The higher position may allow for greater valve expansion, which is especially necessary in small bioprostheses. The restrictive effect of the surgical valve ring is increasingly modified by a technique that is known as bioprosthetic valve fracture. This method utilizes the inflation of a high-pressure balloon inside the surgical valve either before or immediately after the VIV procedure. As shown in this particular case, we use an Atlas balloon to predilate the 21 millimeter Edward SAV valve, and with a true ID of 19.5 millimeter, and then we can implant a 23 millimeter Evolut R inside. There has been no residual gradient after VIV TAVR. In the near future, we will see an increase in reduced TAVR procedure. While doing TAVR procedure, we should consider the current risk, the commission alignment, leaflet overhang or deflection, and under or overexpansion of the second valve. Furthermore, we should consider the hemodynamic performance of this combination of TAVR in TAVR procedure. For instance, although the current risk is lower in TAVR with the use of short frame balloon expandable valve, and the risk is extremely high for the use of TAVR in TAVR with 2 layers of self-expanding long frame devices. Even though the use of balloon expandable valve in the balloon expandable valve for TAVR in TAVR is the current risk is lower. However, hemodynamics may be an issue. In this report, a patient with a balloon expandable valve in balloon expandable valve had a high post-procedure gradient and require surgical valve replacement about 1 year after the reduced TAVR. As to the reduced TAVR with BEV in SEV, although hemodynamic function was acceptable, but leaflet overhang and the higher current risk were noted. The good and bad of various combinations are shown here. The current risk level are high in SAVR Extremely high current risk and the questionable residual gradient are seen in this combination. For BEV in BEV, although less limited the current reaxis, but higher residual gradient can be expected. In BEV in SEV combination, lower residual gradient can be expected, but the current risk is elevated. The best combination might be SEV in BEV because this allows less limited current reaxis and lower residual gradient. That is the fluoroscopy of a patient with SEV in BEV. So, valve choice today is also a valve choice for tomorrow. In conclusion, hemodynamics are increasingly important for both SAVR and TAVR. An important objective for the operator is to ensure optimal hemodynamics that will enable the best possible clinical outcome for patients with valvular heart disease. As we move to more active, younger patients, an EOA of at least 2 centimeters squared is a worthy goal. The lesson learned from the valve-in-valve for small surgical valves while enable optimal hemodynamics could be translated to those with failed transcatheter balloon expandable valve and the small native aortic valve. Available data support the use of TAVR over SAVR and favor the use of self-expanding valve over with supraannular leaflets to achieve optimal hemodynamics, especially in small annuli. I thank you for your attention.